Hi, my name is Jenny Sloan. I'm the Senior Behavioral Health Clinician and Associate Trainer at Star Commonwealth. We're going to begin by outlining suicide as a pre-existing condition prior to the COVID-19 pandemic. We're going to discuss identifying risks and the impacts of COVID-19. We're also going to discuss assessment and intervention, highlighting some focus on tools and resources we can use to make our roles more effective and impacting those most vulnerable to the risk of suicide. We're then going to discuss hope for transformation, hope for our clients who are suffering greatest, and what we can do to forward the movement of awareness to eventually end the pandemic of suicide. So we want to begin by getting a better understanding of suicide as a public health crisis and pre-existing condition prior to COVID-19 pandemic. Prior to the genesis of the COVID-19 pandemic, suicide in the United States had emerged as a rapidly evolving public health crisis. We're going to be reviewing statistics from 2017, according to the Centers of Disease Control and Prevention, by various demographic variables. The following data is provided by the CDC. From 1999 through 2017, the age-adjusted suicide rate increased by 33%. Let's look at some key findings at a glance. From 1999 through 2017, suicide rates increased for both males and females, with greater annual percentage increases occurring after 2006. When I refer to males and females, I am referring to binary organized groups. Suicide rates for females aged 10 to 74 were higher in 2017 than in 1999. Suicide rates for males aged 10 to 74 were higher in 2017 than in 1999. The difference in age-adjusted suicide rates between the most rural and most urban communities were greater in 2017 than in 1999. Rates certainly did increase. Now, as we learn more about the phenomenon of suicide, and this is why the definition of suicide is important to understand. The phenomena is only accurately understood when we understand that the deliberate taking of one's life is what defines suicide. So this is where it's important to tease out non-suicidal self-harm, opioid overdose, or accidental death in any other way that may appear as if a person has intended to take their life. So this is where we'll talk a little later about what is known as a psychological autopsy, which helps us understand what precipitated the person's process towards suicide. Now, the study that the CDC published in increases from 1999 to 2017 reported increases across almost all groups. When we talk about the statistics, we tease out the statistics comparing male and female. It's important also to note that the definition or grouping of male and female is based on a binary system and a binary code. So I want to just make sure that this study distinguishes cis male and cis female and does not distinguish whether trans male or trans female or gender nonconforming folks are identified in any of these subgroups. We'll talk a little more later about intersectionality and risk and how the LGBTQ plus community fits very tragically at the core of risk when we talk about intersectionality. That said, suicide rates were significantly higher in 2017 compared with 1999 in both of these subgroups, the highest at risk being people aged 10 to 14, so adolescents, 15 to 24, 25 to 44, and 45 to 64. This was true for both females and males. The age-adjusted suicide rate for the most rural counties was 1.8 times the rate for the most urban, which is significant to note. Since 2008, suicide has ranked as the 10th leading cause of death for all ages in the United States. The 10th leading cause of death for all ages in the United States. In 2016, suicide became the second leading cause of death for ages 10 to 34. The second leading cause of death for ages 10 to 34. and the fourth leading cause for ages 35 to 54. Although the Healthy People 2020 efforts target is to reduce suicide rates to 10.2 per 100,000 by 2020, suicide rates have steadily increased in recent years, and this data is pre-COVID-19. We're going to talk about the impacts of COVID-19 later on in this space, but it is important to understand suicide as a public health crisis in the United States in this way prior to COVID-19. Before we discuss the impacts that are known apparently and unapparently through data that's been collected, I want to acknowledge that for the purposes of this study, I want to keep in mind that this data set expresses the trends in suicide mortality from 1999 and 2017 in the United States by sex, age group, and urbanization level of the decedent's county of residence. However, race, socioeconomic status, sexual orientation, gender identity, citizen status, body ableness, and other factors that indicate the risk and the degree of vulnerability to other public health crises are not included in this data set specifically. So we'll talk later about intersectionality and vulnerability where it applies to risk for suicide and other contributing factors. And that said, while this data is focused on trends in the United States, I'd be remiss if I didn't acknowledge the fact that as a global community facing this pandemic, we see that many universal trends fixed with risk are certainly notable and important to discuss. Not since 1918 has a culture or a globe been impacted in this way and faced with these challenges. And so I want to impart the importance of looking at these trends as a pre-existing condition. And certainly over the past year, we've seen rates in anxiety, depression, violence, aggression. All of these symptoms and all of these reactions show up in our community, and risk of suicide and trends of suicide across all regions of our globe is no exception. So we just want to tease out here some of the striking pieces of data to pull away from these data sets. Suicide is the second leading cause of death among people aged 10 to 34 in the United States. Suicide is the 10th leading cause of death in the US. The overall rate of suicide has increased by 31% since 2001. And 46% of people who die by suicide had a diagnosed mental health condition. 90% of people who die by suicide had shown symptoms of a mental health condition, according to interviews with family, friends, and medical professionals. This is what I referred to earlier as a psychological autopsy. Lesbian, gay, bisexual, and trans youth are 4 times more likely to attempt suicide than heterosexual cis youth. 75% of people who die by suicide are male, and transgender adults are nearly 12 times more likely to attempt suicide than their non-trans peers. Annual prevalence of serious thoughts of suicide by demographic group include 4.3% of all adults, 11% of young adults aged 18 to 25, 17.2% of high school students, and 47.7, nearly 50% of lesbian, gay, bisexual, and trans high school students. We'll discuss some personal, family, and community trends affixed with risk. 43.3% of U.S. adults with mental illness received treatment in 2018. 64.1% of U.S. adults with serious mental illness received treatment in 2018. 50.6% of U.S. youth aged 6 years old to 17 years old with a mental health disorder received treatment in 2016. And the average delay between the onset of mental illness symptoms and treatment is 11 years. The average delay between the onset of mental illness symptoms and treatment is 11 years. Annual treatment rates among U.S. adults with any mental illness by demographic group include 34.9% males, 48.6% females, lesbian, gay, or bisexual, 48.5%, nearly 50%, 24.9% among non-Hispanic Asian community, 49.1% among non-Hispanic whites, 30.6% among non-Hispanic Black or African Americans, 31.8% among non-Hispanic mixed or multiracial or mixed race groups, and 32.9% among Hispanic or Latinx community members. 11.3% of U.S. adults with mental illness had no insurance coverage in 2018. 13.4% of U.S. adults with serious mental illness had no insurance coverage in 2018. And 60% of U.S. counties do not have a single practicing psychiatrist. Access to health care is key, as this data bears. Access to appropriate health care in a timely fashion is significant, as this data bears. Quite simply, the longer the signs go unseen, unheard, unspoken, the longer the treatment is delayed, interrupted, and whether or not services are even available or accessible, depending on insurance coverage, are all significant factors that contribute to increased risk or our opportunity to mitigate risk. These are system factors to consider. So we just reviewed some startling material. These statistics are almost unimaginable. And this is why we lead the conversation with the data. The 10th leading cause of death in the United States. The second leading cause of death for ages 10 to 34. These are the factors that stand out to me most. This is a good opportunity for you to sit back, let this work on you a little bit, and reflect on what stands out to you. Was there a group you thought wasn't as impacted by suicide that you're learning about today, in fact, is greatly impacted by suicide? What pieces of stigma or stereotype, what areas of shame or discomfort have shown up? And ask yourself, why are you surprised to learn this? What was it you were thinking about this group where the phenomena of suicide is concerned? Were you surprised that some groups weren't as impacted by rates of suicide? Take a moment to reflect. Take a moment to feel the discomfort. Knowing that your feeling of discomfort right now is telling you many important things, chief among them, that you're in the right space. If we're not uncomfortable, if we're not moved, then we're in no place to take action. Becoming aware of such tragic numbers, becoming aware of such tragic risk is a part of stepping into a space of resilience. So next we're going to talk about self-injury or self-harm or non-suicidal self-injury, as we're going to be talking about it. Understanding that, again, suicide is a means to end one's life, while self-injury is a dysfunctional method of temporarily coping with various brands of emotional pain. So we're thinking about intentionality here. It's important to distinguish self-injury from suicide because self-injury is not necessarily a suicide attempt, though it may look and seem that way. For some, self-injury allows for a physical expression of overwhelming internal emotions, and for others, it serves to temporarily relieve stress and anxiety caused by these emotions. Some people don't even feel the injury when they cut, and some use it as an attempt to bring themselves out of a numb state. According to the International Society for the Study of Self-Injury, this behavior is defined as the deliberate, self-inflicted damage of body tissue without suicidal intent, and for purposes not socially or culturally sanctioned. The first thing to understand about non-suicidal self-injury is the harm that results from self-injury is an intentional or expected consequence of the behavior. Risky behaviors that could result in harm, such as not wearing a seatbelt while driving or accidental harm that may occur when playing extreme sports, are typically excluded from our definition here. So it's about intention. Second, self-injury usually results in some sort of immediate physical injury, including cuts, bruises, scratches, or marks on the skin. Behaviors that do not directly result in injuries are usually excluded, even though they may be harmful or dangerous. For instance, food restriction is typically not considered a form of self-injury, since the associated physical damage tends to build up over time instead of happening all at once when the behavior occurs. So we're talking about immediate impact that defines self-injury, not something that's sustained over time. We'll talk more about how to distinguish these behaviors from other types of unhealthy or self-destructive behaviors that may not fit into the category of non-suicidal self-injury. Third, self-injury is separate from suicidal thoughts or behaviors in which individuals want to end their lives. People usually report that they have no expectation or intention to cause death when they engage in self-injury. In fact, in some cases, self-injury may be used to manage intense distress that may associate with suicidal thinking. Fourth, behaviors that might cause physical damage but are acceptable in our society or part of a recognized cultural, spiritual, or religious ritual are not considered self-injury. For this reason, body modification, body piercing, or tattooing are not usually considered forms of self-injury. Although the most common manifestation of self-injury involves cutting oneself with any sharp or jagged object, self-injury encompasses a range of other destructive behaviors, such as burning, wound interference or picking, hitting, hair pulling, and even breaking bones. In fact, much self-injury becomes a pattern of behaviors that are ritualistic. The individual must use the same tool, cut in the same places, maybe the same time of day, the same private setting, etc. Important information to have about non-suicidal self-injury is that it may include scratching, burning, ripping or pulling skin or hair, swallowing toxic substances, self-bruising, and breaking bones. Self-injury may occur on any part of the body, but it is most common on the hands, wrists, stomach, and thighs. The term self-inflicted injuries refers to suicidal and non-suicidal behaviors such as self-mutilation. Keeping our clients, students, and other folks we serve in mind, it's important to think about other examples of non-suicidal self-injury. Let's think about what the behavior looks like, how it's expressed with the individual, when it may occur, what might be driving or why the behavior, and again, where this might be happening. We're also going to look at the frequency. Is this episodic? Once in a while, that is. Does it happen on a chronic basis? Is there some sort of tempered pattern we can identify? Is it sporadic or spontaneous or situational? Is it crisis-driven? We want to look at all of these factors that surround the behavior, identifying the behavior, who's noticing, where it's being noticed, and how often. The notion that self-injury can become a cycle brings us to a discussion about the neurochemistry of pain and response to pain. So the act of cutting, for instance, which is a commonly identified, not necessarily commonly understood example of non-suicidal self-injury, but it's a commonly identified way in which we see this occur. So cutting releases brain chemicals called endorphins, which these are the same chemicals that are released that provide what we know as a runner's high. Some researchers think that the pain relief of the endorphins actually soothes some people, at least in the short run. So it's this chemical interaction that we want to explore in terms of how does the behavior produce the release of a chemical that ultimately brings a sense of soothing to the individual in the short term. So a common misconception here is that individuals cut in order to introduce or induce physical pain to punish themselves in some way, or that this is considered a violent means of self-mutilation. However, what defines non-suicidal self-injury is what drives the behavior and how it functions for the individual. So cutting is an unhealthy means of externalizing pain that is deeply internalized. In other words, it's not a behavior that is carried out to induce pain, but to get relief from it by transforming it from mental anguish, physical or psychic pain, which ultimately prompts the release of the soothing chemicals that externalizes it into a physical pain. So the relationship between non-suicidal self-injury and suicidal ideation and attempt is complex. While non-suicidal self-injury is not engaged with a conscious intent leading to suicide, non-suicidal self-injury is the single most reliable predicting factor for later ideation and attempt. So it's a predictive factor, not necessarily an indication of an attempt or an ideation. So it's important to distinguish that. That's how we want to understand that very complex relationship. Next, I think it's important to review some myths and facts. A common myth or misconception is that people who talk about suicide won't really do it. Well, I hope we've made the argument in this space that not talking about it actually increases risk. I hope that we've made the argument that it's important to talk about it and that we want people to talk about it. So that myth that people who talk about it won't really do it is just that. Almost everyone who attempts suicide has given some clue or warning. So don't ignore even indirect references to death or suicide. Statements like, "You'll be sorry when I'm gone," or "I can't see any way out," no matter how casually or jokingly it's said, may indicate serious suicidal feelings. Another misconception: anyone who tries to kill themselves must be crazy. While mental health and mental illness and childhood trauma and toxic stress are all experiences of challenge, crisis, and tragedy that can contribute, most suicidal people are not psychotic or insane. They are upset, grief-stricken, depressed, or despairing, but extreme distress and emotional pain are not necessarily signs of mental illness. Let's return to what we know is our trauma-informed care principle. It's not what's wrong with you, it's what happened. And in this vein, we're talking about experience. Who among us has not experienced distress, emotional pain over this time? Perhaps despairing grief over the loss of loved ones. These are our normal responses, common responses to abnormal experiences. Another common misconception is that if someone is determined to kill themselves, nothing is going to stop them. Even a very severely depressed person has mixed feelings about death, fluctuating between wanting to live and wanting to die. Rather than wanting death, they just want the pain to stop. And the impulse to end their life does not last forever. We'll look at some information later on in this space that talks about the immediate fluctuation of moods from hour to hour, day to day, in fact, when we review some of the suicide risk assessments and suicide monitoring tool that are widely used and considered gold standard protocols in suicide risk, we see that moods can shift very, very acutely from hour to hour. So again, the myth that if someone is determined to kill themselves in one moment and that nothing's going to stop them in the next is just that, a myth. Another misconception is that people who die by suicide are people who were unwilling to seek help. I hope we're remembering the data that we reviewed earlier in this space. How many people did seek help? How many of those who died by suicide didn't have access to the care they needed to get the help they required? So that myth that people who die by suicide are people unwilling to seek or receive help is just that. Many people try to get help before attempting suicide. In fact, the studies that we reviewed earlier in this space and many other studies indicate that more than 50% of suicide victims had sought mental health help, or medical treatment in 6 months prior to their death. Another common misconception is that talking about suicide may give someone the idea. This harkens back to one of the first misconceptions we discussed. Talking about it doesn't increase risk of completing suicide. Talking about it, in fact, reduces risk of completing suicide. For most folks that you'll talk with who have experienced significant suicidal ideations or attempts, that deep psychic pain is what promotes the idea of escaping that deep psychic pain. Suicide as an act, or an epidemic as referred to in some communities, where series of youth have taken their own lives in a series of, in a sequential pattern. Talking about it, it extracts the shame and the guilt and the stigma, and inviting someone to bring their pain into a space where connection is capable of happening with and for them. That's what we know to do here. So we definitely want to debunk the myth that talking about suicide is what's going to give someone the idea of completing it. So in identifying risks, we're going to look at trauma, anxiety, stress, and depression. And these are some on-top identifiers across many groups. This is where advocacy groups, groups that promote awareness, begin creating spaces to talk about these very stigmatized and often shame-laden experiences of struggle. And as much as it's hard to talk about suicide, let's talk about the contributing factors and why it's hard to talk about those. It isn't easy to talk about the experience of one's trauma. It isn't easy to express their experience of anxiety. It isn't easy to confess that you feel stressed or depressed. These are highly stigmatized conditions, which again contribute to barriers to discussing them and bringing greater awareness to a person's experience of any one of these conditions. But what we know is that talking about it begins to deflate the stigma, reduce shame and guilt surrounding a person's honest expression of experiencing any one of these conditions. And talking about it in organized and safe spaces also brings about the opportunity for the one thing that drives isolation, and that's connection. So we want to give respect and reverence to organizations, local, national, regional, global, who are bringing people together to talk about the things we don't want to talk about, to create spaces where people can honestly express their experiences of challenge, whether it's with trauma, anxiety, depression, and stress. And while these are all pre-existing conditions, I think most of us on the planet right now, if we've never experienced any of these conditions in a very pronounced fashion, most of us can say that we've experienced it this year, whether in one area, multiple areas. Some of us were surprised by feeling what we feel. And in this past year, we've also begun to normalize conversation surrounding it. And when we listen to our neighbors, we listen to our students, we listen to our coworkers, our colleagues, talk about their experience of being shelter in place, for instance, not being able to be in school, not being able to be connected to a community group or a club, not being able to be in person. All of us on one level or another can seriously understand the effects that such isolation have had on our bodies, on our minds, on our spirits. We're going to talk about risks that the pandemic have further imposed on already very vulnerable groups during this time as we discuss challenges to the LGBTQ youth community, communities of color, communities of underprivileged, underinsured, underserved resources, and how we can best identify and step forward toward assisting with prevention. If we can find a way to celebrate a person's courage in telling us the scariest, most painful thing that's going on inside them, we can really begin to have a normalized and healthy conversation that, while it involves discomfort, ensures safety, because that is what our suffering brothers and sisters and friends need. A safe place where the discomfort and the pain can be shared and a means of connection with other people. It's the isolation and the stigma and the unspoken message that no one wants to hear about it and we cannot talk about it keeps our friends in crisis alone. So the more we're able to have these conversations, the better able we are to identify risks. So when we identify the risks, we have some approaches to take. We want to invite the person who we may be concerned about to talk about their experience and what we can do to help. And some of those risks are common risks include, but are not limited to, change in eating or sleeping patterns. Of course, this is true of all of us in post and present COVID-19 pandemic. And so this is one of the other areas of COVID-19 specific risks that we really want to look at, because when and if most of us, whether in a temporary state or overall, have exhibited changes in eating and sleeping, we don't want those who have greater risk, we don't want those whose symptoms are really expressed in these patterns to go unnoticed, because we're all adjusting in a way. So these are common risk factors, and some of us may be exhibiting that because our time and space and orientation has been altered this past year. But ever more important than to consider these risks when we're looking at folks that might be struggling with ideations or depression or anxiety or anything contributing to the risk of suicide. So we look at the change in eating and sleeping habits, withdrawal from friends, family, and regular activities. That's all of us right now. But again, we don't want that risk factor to get lost in our altered way of life and recovering from these altered ways of life. Violent actions, rebellious behaviors or running away, drug or alcohol use or abuse, unusual neglect of personal experience. So this is beyond going to work in your sweatpants from home, marked personality change, persistent boredom, difficulty concentrating, or a decline in the quality of schoolwork. Now we realize that all of our students are experiencing risk here, and we've seen some of our high-performing students decline because they're not thriving through the virtual experience, that maybe they need that in-classroom connection. They need to show up every day and be seen by their classmates. So the phenomena I'm hearing educators talk about, when the camera's off versus when the camera's on, what the students appear to be looking like. Is being disheveled or a lack in personal appearance, is it indicative of something? Or is it a teenager who doesn't have to get dressed for school in a particular way, right? So we're considering all of these different factors, why we're seeing what we're seeing, why a student might be declining in their schoolwork. And we don't want to lose that. We don't want to get into a default mode of, oh, well, that's just a byproduct of the pandemic, or that's just a byproduct of shelter in place or remote learning. That may very well be. That may very well be. But we don't want these risk factors to get lost in what we're used to seeing and considering, and maybe even dismissing in the time of COVID-19. Other risks include frequent complaints of physical or psychosomatic symptoms, such as stomach aches, headaches, fatigue, loss of interest in pleasurable activities, some of which are not available to us perhaps because of shelter-in-place requirements. The risk of being intolerable of praise or rewards. So someone that just can't take in the good news about themselves. This is indicative of self-esteem issues, self-valuation. And when we talk about suicide, beyond the definition of it being an act that is deliberately taken to end one's life, we have to understand that suicide is not about necessarily wanting life to end, but it is more about wanting the pain to end and finding no considerable alternative to the end of that psychic pain. So that's the focus we need to lend. How does a person show me they're in pain? How can I invite that person to share their degree of pain in any way? Because that's what really the risk factors are drawing us toward. What is your experience of pain? How is that showing up? And what can I notice about you to get to a closer proximity of your psychic pain? Because that's what this is about. It is not about choosing death. It is about relieving oneself of the extraordinary psychic pain that makes it an unlivable life experience. So keeping in mind, and of course everyone's experience of this type of pain that leads to suicide is individual. There is no common umbrella. Everyone's experience is unique, but it is important to understand that it's about extraordinary pain and the need to be relieved of that pain. According to one recent case control study, 1999, the effect targeting of a handful of risk factors, namely past suicide attempt, psychopathology in the adolescent, parental psychopathology, and a gun in the home, is likely to result in a substantial reduction in the suicide rate among youth. So taking a look at those factors and considering the exponential risk that those who don those factors, the awareness, the step toward invitation into treatment and intervention, can significantly reduce risk of suicide there. And this brings us to this discussion on intersectionality. So before we get into examples of groups and specific risks to groups such as the LGBTQ plus community, we're going to talk about intersectionality as a concept. We want to understand that thoroughly. Intersectionality is defined according to the Oxford English Dictionary as the interconnected nature of social categorizations such as race, class, and gender, regarded as creating overlapping or independent systems of discrimination or disadvantage. This is a theoretical approach based on such a premise. This is where we're identifying the exponential risks and how they relate to one another. And this brings us to more in-depth conversation on the risks presented to our LGBTQ plus community, specifically youth and members of color. Some key findings from the National Survey on LGBTQ Youth Mental Health, published in 2017, reflect that 39% of LGBTQ youth seriously considered attempting suicide in the past 12 months, with more than half of transgender and non-binary youth having seriously considered. 39% of LGBTQ youth considered attempting suicide in the past 12 months, with more than half of that number of youth who are transgender, more than half of transgender and non-binary youth seriously considered. The 12-month piece is something to consider. Keep in the back of your mind when we talk about the suicide risk assessments and procedures that are the gold standard protocol currently used, and the suicide risk and monitoring. We're talking about length of time. This is something to bear in mind when we discuss assessing for risk. How often, how long, how frequent. From this same study, From the National Survey on LGBTQ Youth Mental Health, the same study, 71% of LGBTQ youth reported feeling sad or hopeless for at least 2 weeks in the past year. Again, we're looking at how long is this happening, how frequent does it happen. Less than half of LGBTQ respondents were out to an adult at school, with youth much less likely to disclose their gender identity than their orientation. Key findings include, continued, 76% of LGBTQ youth felt that the recent political climate impacted their mental health or sense of self. 87% of LGBTQ youth said it was important to them to reach out to a crisis intervention organization that focuses on LGBTQ youth. And 98% said that a safe space for social networking that includes LGBTQ youth would be valuable to them. This data is all published through the Trevor Project, through the National Survey on LGBTQ Youth Mental Health published in 2019, through the Trevor Project, which is one of our highly recommended resources. While we have no formal partnership with the Trevor Project, they are one of our most encouraged and celebrated organizations who are doing wonderful work with outreach, awareness, and providing training and materials for folks in need. Identifying intersectional risk factors across many mediums is essential. So when we discuss who's at greatest risk, isn't everybody experiencing depression, anxiety? Well, much like the ACEs study, if we know that there are risks in unassuming areas, or formerly unassuming areas, and we understand how these risks can predict future behavior, we're already in a space where we're informed. So to put simply, we wouldn't necessarily assume that a person, let's say a person of a LGBTQ community, isn't exhibiting symptoms of depression. They're highly functional, they seem well-adjusted, or our most vulnerable population within the LGBT community are trans youth of color. And they're functioning fine, or so it seems. Just knowing that these factors, affixed with the fact that they are part of some of the most marginalized communities in our society, lets us know that we need to pay close attention to how they're functioning. Because just moving in the world, whether they exhibit classic or apparent signs of any of these risk factors contributing to suicide, we know that simply being a part of a marginalized society puts them at risk for not just suicide, but community violence, hatred, exclusion, discrimination, all of the other isms that function to damage our most marginalized populations. So we want to include our understanding on how the systems of oppression and inequity present a sort of prelude of risk in our society as we're living in it now. According to the American Psychological Association, there is a higher prevalence of mental health disorders in the LGBT community than in the heterosexual community. LGBTQ individuals are almost 3 times more likely than others to experience a mental health condition such as major depression or generalized anxiety disorder. This fear of coming out and being discriminated against for sexual orientation and gender identities can lead to depression, post-traumatic stress disorder, thoughts of suicide, and substance abuse. This comes from the National Alliance on Mental Health statistics published in 2018. So again, that illustrates the experience of being a member of a marginalized group put this group 3 times more likely to experience these conditions, which can lead to suicidal ideation and completing suicide. So next we're going to be reviewing assessment and intervention. Specifically, we're going to do an overview of the Columbia Protocol, which is the gold standard in risk assessment. We're going to review the Erbacher SRA protocol, that's Suicide Risk Assessment Protocol. And then later on, we're going to talk about more informal or general ways we can assess risk through observing behavioral clues, verbal clues, keeping our eyes and ears open across settings. Upon completion of this course, you may want to ask some questions of colleagues or administrators in your district or your hospital or your clinic if you're not familiar with what tools may be in place, what assessments are provided or encouraged, or if so, and you're not feeling comfortable on how to use them, definitely reach out to people that do. And if nothing is in place, you may want to consider these assessments and interventions as tools to recommend to the leadership in your community. I'm going to introduce the Columbia Lighthouse. The Columbia Lighthouse Project's mission is to light the way to ending suicide. Their message, like the Columbia Protocol itself, is simple. Just ask. You can save a life. So some background on the Columbia Protocol. This protocol was created by Dr. Kelly Posner, who's the founder and director of the Lighthouse Project and a professor of psychiatry at Columbia University, also a decorated health professional. Dr. Posner's work has been described as life-saving and extends across 6 continents. Here are some things that have been said about her work. Her work to assess and prevent suicide has been likened to the advent of antibiotics and described as, quote, nothing short of a miracle by the United States Department of Defense. The CDC noted that her work is, quote, changing the paradigm in suicide risk assessment in the US and worldwide. The Columbia Protocol, also known as the Columbia Suicide Severity Rating Scale, is known as the gold standard in assessment. It's utilized to assess risk in 50 states and, quote, supports suicide risk assessment through a series of simple, plain language questions that anyone can ask. The questions help users identify whether someone is at risk for suicide, assess the severity and immediacy of that risk, and gauge the level of support that that person needs. One of the reasons it's regarded as the gold standard is because the FDA has characterized this work as, quote, setting a standard in the field, unlike any other in recent history. Again, it's policy across all 50 states in the United States, and it's incorporated in national agencies and in most countries. It's viewed as the most important research in the study of suicide in recent history, and above all, it's free to utilize. The toolkits, the guidelines, the support, and all the information are available online and free to download. Let's talk a little more about the Columbia Suicide Severity Rating Scale, or the CSSRS as it's known. It does 3 main things. It, 1, helps determine whether and when an individual has thought about suicide or experienced suicidal ideation. 2, it assesses what action the individual has taken and when to prepare for suicide. And 3, it assesses whether and when the individual has attempted suicide or began a suicide attempt that was either interrupted by another person or stopped on their own volition. There are 3 assessment options here. 3 different options to select from based on your professional setting. 1 can be used to help assess families, friends, and neighbors. 2, healthcare and other community settings, including first responders, military, government, school, and corrections. And 3, research. Across all these domains, the first step includes the triage, risk, and identification series of questions. I'd like you to direct your attention to this chart where these 6 questions are expressed and guidelines for how to utilize or code the answers to the questions and who to contact depending on the responses to the questions. It's all laid out right here. Here are the 6 questions. Number 1, have you wished you were dead or wished you could go to sleep and not wake up? Number 2, have you actually had any thoughts about killing yourself? And now here in the gray margin, we have a guideline. If the individual answers yes to number 2, answer questions 3, 4, 5, and 6. If the individual answers no to number 2, go directly to question 6. So a takeaway here is that we always ask question 6. If the individual responds yes to question 2, we go on to answer questions 3, 4, 5, and 6. Question 3. Have you thought about how you might do this? Question 4. Have you had any intention of acting on these thoughts of killing yourself, as opposed to you have the thoughts, but you definitely would not act on them? Question 5. Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? Now, you'll note in the chart that answers yes to 4 and 5 will place an individual at high risk. Please note, going back to question 2, if the individual answers yes to question 2, you must ask 3, 4, and 5. And regardless of their response to question 2, we're always asking question 6. Have you done anything, started to do anything, or prepared to do anything to end your life? Examples include collecting pills, obtaining a firearm or a gun, giving away valuables, writing a will or suicide note, holding a gun but changing your mind, cutting yourself, or trying to hang yourself. These are just some common methods, but this list is not exhaustive. Below you'll also see the hotline number, the lifeline number to the National Suicide Prevention Lifeline, and another guideline. Any yes indicates that someone should seek a behavioral health referral. However, if the answer to number 4, 5, or 6 is yes, seek immediate help. Go to the emergency room. Call 1-800-273-8255, text 741-741, or call 911, and stay with the individual until they can be evaluated. So here we have described low risk, moderate, high, and life-threatening, and the subsequent steps to take and people to contact depending on those responses. Now, one thing we want to note about these questions. These 6 questions are the same across all variations of this assessment. So whether you're a nurse in a hospital, whether you're a primary care physician, whether you're a teacher, a paraprofessional, an office assistant, these list of folks are considered, quote, askers. So these are all qualified askers of these questions. Should a student, a client, a patient need to be assessed for risk? The answers on this provide the information needed to classify someone's suicidal ideation and behavior, and when combined with clinical judgment, can help determine levels of risk and aid in making clinical decisions about care. Here we're going to take a look at the Erbacher and Singer study that was published in 2018 and revealed a blind spot, so to speak, of many common suicide risk assessments. From their study, they created the suicide monitoring tool, which is designed specifically to be used in schools. What they found from the study was that the suicide risk monitoring was what was missing from suicide risk assessments. Almost half of identified at-risk youth occur in school settings. Issues addressing suicide risk, for instance, time constraints, limited research, meaning that a lot of it has taken place in the clinical settings and hospital settings versus the school settings. And they also revealed some myths about the trends surrounding these. Among the study findings included a summary of the current standards, which only assessed for risk. It discussed the best practice for suicide risk assessment included assessing for suicidal ideation, intent, planning, identifying protective factors as well as risk factors, warning signs, identifying lethal means, assessing for guardians' capacity to provide a safe environment, and to gather information from multiple sources. Suicide risk assessment should include school stressors like standardized testing and social events. Study findings also included that many elements of a suicide are planned in advance. Research with adults shows that final details of methods, where and when, happened just days or hours before it occurred. The study also revealed that suicidal ideation can fluctuate within hours. The study revealed that a plan can include writing a note, access to the intended method, and recent attempts. We're going to talk about the suicide monitoring tool that was generated in response to the outcome of their study. The suicide monitoring tool creates a mini safety plan or student precaution plan, as noted in the Columbia Protocol. It's a plan that addresses reasons for living, the people they identify as support, and a question of what could you change about your life that would make you not want to die. So a focus on future thinking and possibility and an incorporation of imagining protective factors versus simply focused on the risk itself. The suicide monitoring tool is the missing piece in risk assessment, as it is a monitoring tool designed to be used with youth who have been identified as at risk for suicide. Data and information is easily collected and can be shared with providers and other systems. The suicide monitoring tool tracks changes in youth already identified as at risk, including those who are identified and remain in school or those coming back to school from hospitalization. These resources, materials, and tools, as well as opportunities and information for training, consulting, and partnering with school districts, is available on the Erbacher website, where there are also free downloadable worksheets and toolkits for parents, school personnel, struggling youth, family members and friends who may be identified as those protective factors in their circle of support. So becoming more familiar with and confident using the tools and resources affixed with the Columbia Protocol and the Erbacher and Singer resources, as well as the suicide monitoring tool, we can see where there is real possibility and resource for us to enhance our skill set as effective helpers. And with all of these skills and perspectives in mind, we know what to listen for, we know what to watch for, we know what to look out for and anticipate. With all these resources and tools at our fingertips, we can be effective agents of change. We can be those curious, compassionate, watching over those we serve in school settings, hospital settings, in our clinic, wherever it is, we're helping. I can't emphasize enough. As the second leading cause of death for children this age, for the clients and students and patients you serve who are at risk, this is imperative information to have. These are paramount skills to build. Be prepared. Become familiar. Get uncomfortable. This is hard material to take in and realize. But in doing so and stepping into a space of resilience, we can transform this reality as something of the past versus a dreaded reality of the future. These tools and resources and the confident skill sets that you need in order to impart them can be life-saving, has been life-saving, will be life-saving. Be prepared. Take the necessary steps within your sphere to get comfortable not with the reality of suicide among our young people, among our brothers and sisters and neighbors. But get comfortable using these tools. Get comfortable looking in that direction. Get comfortable asking those questions. Because without asking, the answer is always going to be, I don't know, and a mystery. And that's really what's terrifying about this process, is not knowing how to be helpful, feeling helpless and hopeless, which is again what the individual who's suffering with deep psychic pain is struggling with. We can get through the discomfort and be helpful. And if we can do that for those we serve, that also serves as a symbol of hope that they can do the same to save their own lives and move on and thrive in a space of resilience and post-crisis growth. Ultimately, that's what we're aiming to do with and for and by our client side. So while there may be very few, if any, ways to look at this time giving us any advantage in this area, one thing we can say is that over this past era of COVID-19, what has occurred among our communities, starting at the dinner table, within the office, neighborhood gatherings, in spiritual worship places, other places where folks gather, is that we've been talking more about how we feel, more now than ever, simply because we have to. We're talking more about our experiences of anxiety, depression, fear, anger, terror in some instances, grief and loss. The challenges that COVID-19 has brought about, the global community that we share, have invited us to bring more normalized approaches to talking about very difficult emotions. So in a sense, this is good news. As we grow stronger and more capable of managing discomfort, not just surrounding specific factors related to COVID-19, but also the other reckonings that we're grappling with, long overdue reckonings. We're deliberately putting ourselves in uncomfortable positions. We're deliberately leaning into the discomfort that's necessary in order to have these critical conversations, all of which include a sharing of our experience, our own experience of difficult spells, trauma, anxiety, depression. These are conversations that this era has forced us to start having with one another in order to survive it. So let's include conversations, preparations, and invitations to discuss suicide. Raising awareness absolutely does and will save lives. So thank you for being here today and leaning into this very difficult space so that you can also be a very important champion.